My name is Randy Hecht, and I'm a GI oncologist at UCLA. I'm happy to talk about precision and strategy redefining advanced colorectal care. This is based on a CME session that I did with my colleagues Dominic Modeste from Charité in Berlin, as well as Kanwal Raghav from MD Anderson. One thing that we have learned is that colorectal cancer is certainly not one disease, and over the last particularly decade, we've learned that it is important to understand biomarkers and how we treat our patients, as well as we know that there are new treatments that have already been approved, and there will also be treatments that hopefully will be approved in the near future. Colorectal cancer is still the second most common cause of cancer death in the United States, with about 150,000 cases and about 50,000 deaths. Unfortunately, while colorectal cancer is a disease of middle-aged and older patients in general, there's been a significant increase in patients under the age of 50, and the reasons for that are really not totally clear. The one thing that we do know is that those patients tend to be diagnosed a little bit later, and that they do respond to the treatments that we already have. So we're talking today about advanced colorectal cancer. First-line treatment has not really changed that much over the last 2 decades, but finally there are beginning to be some differences. And one of the most important things that we have learned is that, like our colleagues in breast cancer and our colleagues in lung cancer, is that biomarkers are really critical. While historically it really didn't matter what the biomarkers were for first-line and second-line therapy, this has changed. Now, up until about 5 years ago, most patients did not necessarily get biomarker testing in first line. What's happened has really been a revolution, both in tissue-based, which takes a little bit longer, as well as ctDNA or liquid biopsy, and that really does change how we treat patients. The most important biomarker probably is actually mismatch repair, or MSI, because patients who have deficient mismatch repair, also called MSI high, which is only about 3% of patients with metastatic colorectal cancer, have a completely different course and completely different treatment. That should be actually done on the biopsy that diagnose colorectal cancer, because that may also identify patients who have inherited predisposition or Lynch syndrome. There are a number of different ways this can be done: by tissue, by immunohistochemistry, or next-generation sequencing up front. This will also identify those patients. What we know is that patients who are MSI high, or whose tumors are MSI high or deficient mismatch repair, are pretty resistant to standard chemotherapies. However, these patients also are extremely sensitive to immunotherapies, and this goes back to really the first trials in the advanced setting done by Deng Li that showed that checkpoint inhibitors, PD-1, in that advanced setting, those patients had a very high response rate and durable duration of response. So the first approval in first line, which is when these patients really should be treated, was with the KEYNOTE-177 trial with pembrolizumab. And compared to chemotherapy, there was a major improvement in response rate as well as overall survival. This led then to the CheckMate 8HW trial, which was looking at chemotherapy versus nivolumab, single agent PD-1, versus the combination of a PD-1 plus a CTLA-4. And in that, the combination was significantly better, a new standard of care. So for patients who are first line, who are candidates for immunotherapy, which is most patients who are MSI high or deficient mismatch repair, the standard of care now is dual checkpoint inhibitor therapy with nivolumab and ipilimumab. Patients who may not be as good a candidate, I would still say that single agent is still a reasonable thing to do. The other biomarkers that should be tested are BRAF for upfront, KRAS, as well as NRAS, and then for later lines, HER2. So BRAF mutations, which are usually a V600E or class 1 mutation, are found in 5 to 10% of patients with metastatic colorectal cancer. Historically, that group has done extremely poorly. There is an overlap with MSI high, Generally, when those patients are MSI high and have a BRAF mutation, that means they have a sporadic MSI high as opposed to Lynch syndrome. And in that group, they respond as well to checkpoint inhibitors as those patients who don't have a BRAF mutation. Now, BRAF inhibitors as single agents, which have been looked at and have been effective in, for example, in melanoma, as single agents have not been particularly effective in metastatic colorectal cancer. And we came to the realization in translational and preclinical work that there's a feedback loop and you need to have inhibition of EGFR as well as a BRAF inhibitor. So this led to the Beacon trial, which looked at triplet with encorafenib as well as a MEK inhibitor plus cetuximab, and was significantly better than chemotherapy alone. However, the doublet with encorafenib plus cetuximab looked very similar, and that became the approval and the standard of care. This led to the first-line trial, which was called Breakwater, which was run by Scott Kopetz. This looked at the combination of encorafenib, the RAF inhibitor, plus cetuximab, plus standard chemotherapy modified FOLFOX6. This was compared to the doublet alone, encorafenib plus cetuximab versus standard of care chemotherapy. By progression-free survival as well as overall survival, the combination of encorafenib plus cetuximab plus chemotherapy was significantly better than either the biological doublet alone or standard of care chemotherapy. Interestingly, particularly for patients who may not be a candidate for cytotoxic chemotherapy, the doublet of encorafenib and cetuximab was as good as, or unfortunately those patients don't do so well, as good as modified FOLFOX6 alone. One of the other important biomarkers that we have is KRAS. So RAS mutations are found in about 50% of patients with metastatic colon cancer. What we know that it is a negative predictive factor, that patients who have a RAS mutation do not get benefit from anti-EGFR therapies. What we know is that in patients who do not have a RAS mutation, who are RAS wild type and have left-sided disease, that an anti-EGFR in several trials have actually shown benefit with chemotherapy plus an anti-EGFR versus chemotherapy versus bevacizumab. In patients who do have a RAS mutation, there's no benefit from anti-EGFR and possibly even some decrement. Now, RAS has been, as a target, has been a very difficult nut to crack. It's been called the great undruggable target. And really over the last 5 years, based on some really brilliant biochemical work, is that we're finally having RAS inhibitors. The first class of RAS inhibitors, the first group, were G12C inhibitors. G12C, while common in lung cancer, is only about 3% of colorectal cancers. However, there have been trials. There was the CodeBreak 300 trial using sotorasib, which is a G12C inhibitor. And once again, there's a feedback loop through EGFR, so in combination with panitumumab. And in CodeBreak 300, there was significant benefit randomized versus standard of care. And that led to the approval. There's a similar drug, adagrasib. This was combined with cetuximab. This was looked at in the Crystal-1 trial. Once again, a high response rate in a group of salvage patients in the 25% range. Toxicities are similar to what you would expect to an anti-EGFR alone, and this is also approved in this setting. I don't think that it really matters which anti-EGFR that you use, and national guidelines also back that up. These drugs are now approved in the salvage setting for patients whose tumors have a KRAS G12C mutation. Now, while in pancreas cancer and lung cancer, other RAS inhibitors, G12D or pan-RAS, are moving forward rapidly. Those trials are still underway, and I really don't have any data for that. I'd like to finish up with other new therapies. I don't really have time to talk about HER2, but HER2 has been interesting, and there are drugs that are approved with tucatinib plus trastuzumab or famtrastuzumab deruxtecan. There are several drugs that have some activity in the salvage setting. The first was regorafenib, which is a small molecule tyrosine kinase inhibitor, and that is approved, originally starting at 160 milligrams, and then their new novel or now standard dosing strategy starting low and going up high, the so-called redose strategy. There's another small molecule called fruquintinib, which is not as dirty an inhibitor. It really is much more specific for the VEGF pathway. There are two trials, the FRESCO trial in China as well as FRESCO-2, that showed improvement compared to placebo or best supportive care. Trifluridine tipiracil is a cytotoxic. While it is related to fluoropyrimidines, it is different. Has shown activity in patients, once again, versus best supportive care. Interestingly, the combination of trifluridine tipiracil plus bevacizumab was in a phase 2 trial by Pfizer, showed a significant improvement in progression-free survival. This led to a phase 3 trial, the Sunlight trial, that showed at least as much improvement when you add bevacizumab to trifluridine tipiracil. And that, in many respects, has become the standard of care in salvage. But the question has come up about immunotherapy in the setting of the 97% of patients who are MSS. The first trial to look at this in combination, the first phase 3 trial, is the Stellar 303 trial, which I published recently in Lancet. This was a large randomized trial of the small molecule tyrosine kinase inhibitor zanzalintinib plus the PD-L1 of atezolizumab. This was randomized in comparison with a standard of care, which was regorafenib. Since the trial was started, more people have been using TAS-102 or trifluridine tipiracil plus bevacizumab, which seemed to be better than the cytotoxic alone in the Sunlight trial. But the trial that we did was using regorafenib as the control arm. In that trial, there was an improvement in overall survival with a hazard ratio of 0.8. There was also an improvement in progression-free survival as well. Now, one question has been is whether there's a difference between patients who have liver metastases, which is immunosuppressive, and those that do not. And in fact, all subgroups seem to benefit equally with zanzalintinib plus atezolizumab, with the hazard ratio really ranging from 0.78 to 0.80. So we're finally beginning to get new drugs in patients with metastatic colorectal cancer. Some of them are biomarker directed, such as G12C or HER2, or hopefully other KRAS inhibitors. We're finally beginning to get immunotherapies, particularly for MSI high, and then based on the Stellar 303 trial, perhaps in patients with MSS. This is based on a CME discussion that is already online with Medscape. That's called Line by Line, Strategic Decision Making in Advanced Colorectal Cancer. Thank you very much.